All right, Chapter 11, Adolescents. Again, the disclosure statement, I don't own this material under fair use. I'm providing lecture content for only my nursing students using this material. All content within is only for educational purposes and does not provide medical advice. So, adolescents. Oh, we're at the end. Almost there. Then we can get into the good stuff. The stuff about pediatric patients. So we're going to talk more about growth and development, the age-specific physical assessments needed at adolescents, the medication approaches for these guys, variation in nursing procedures for them, the strategies for health promotion amongst adolescents, emergency care, strategies to support the hospitalized adolescent, integrate chronic care concepts in adult health, the beginning of adult health in the adolescent-specific considerations. We're also going to integrate home care concepts in adolescent-specific considerations, recognize complementary and alternative therapies that could be used by adolescents, and recognize child abuse considerations in the adolescent child. Okay. So adolescence, what are we talking about? What's the definition? Typically, it's that transition between childhood to adulthood, and it is considered to have 3 stages. So 3 stages here: early, 10 to 13, so consider preteen, 13, you become a teenager. So 10 to 13 years, your early adolescence. Middle adolescence is 14 to 17. And then late adolescence is 18 to 21, according to the American Academy of Pediatrics. So some people will be in a pediatrician's office and still be 21. Eventually, we want to try to get them into an adult health model where they are seeing a normal adult practitioner instead of pediatrics anymore, because pediatrics really is getting towards the end of that lifespan and more into an adult acute chronic illness. So they really need to transition eventually. But a lot of people love their pediatrician, right? They grew up with them, so they don't want to leave them. I get it. But eventually we need to do that. So adolescence is regarded as a time of extreme personal turmoil. Most adolescents only have mild difficulties during this time of life. Developmental warning signs, school failure, absenteeism, aggressive behavior. So the outcome of this stage is development of advanced cognitive abilities, going to college, going into a whatever profession, right? So that's the whole goal of this, is to get them on their way out of school into a formal education or informal education so that they can be productive citizens. Autonomy and self-identity, big time during this point in time. So we are always talking about giving them a choice, respecting their bodies, and getting friends involved, right? Because friends are really their biggest thing right now, not parents. So really, it's one of those periods in time where you really have to think, is this a child or is this an adolescent in your head? Because you can't treat them as a child. You can't treat them as your child either. So that's a big cognizant thing that you have to remember. These aren't kids. So Piaget, they're in that period of time where 10 to 11, they're in concrete operations. At 12 years old, they go into formal operations. The prefrontal cortex in the adolescent brain is for critical thinking and developing decision making. This is where we want them to think, but they're not. They're thinking behind the brain, so they don't really look at the risks and the benefits of things that they do. They tend to go with their reptilian brain instead of the front. So hit your head and think, oh, I wish my teenager, right? You know this. You know that that's how your parents were too. They're like, oh my gosh, if we can only get these guys fledgling out of the nest and on in their own life. So this is the period of time where they're developing analytical thinking, abstract thinking, getting concerned in politics and social issues, being able to think long-term and setting goals like college or what's going to happen next. They compare themselves with their peers all the time. They begin to have some self-awareness of personal limitations, and they become able to predict outcomes and consequences later in this period, right? So you're not thinking a 10 to 12-year-old is understanding that. Not all of them, right? So there are some kids that are above the curve that have been, latchkey kids for a long time, and they can take care of their siblings. And then there are some you don't want them taking care of their siblings, okay? So this is really up in the air. Physiologically, we know that 10 to 12 is latency and 12 to 18 is genital stage. Just consider that genital stage means the genitals, which is usually where their head is. So, Erickson's were going into embarking on a quest for a personal identity, a sense of self, and that's really through intense exploration of personal values, beliefs, goals. So 10 to 12, their industry versus inferiority. 12 to 18, their identity versus role confusion. 19, they're now in the intimacy versus isolation. So characteristics of those kids: self-conscious, they compare their body with others. Oh my gosh, bikini or no bikini, right? Interested in sexuality and gender roles, so the emergence of sexual feelings and experimentation. They have a need for privacy. They try on different styles of dress, communication, and persona. And they develop personal values. They want to be an adult, but they still need some support of the family caregiver, especially money. Unless they're a babysitter or they have a side job, then they quickly going into the adult world. They have self-image that's dependent on what others think. They have mood swings. Oh my gosh, if you have a bunch of girls, you know this, right? Guys too, though. Feel like they're on stage when others are around and they're paying special attention. They believe that they're special and unique. They're invincible. They're impulsive. And they assume that everybody else has the same perspective as they do. Unrealistic career goals, maybe. They test limits and rules. They know right from wrong, but they will test you. And they can compromise with others when they want to. So remember that as a parent. They can compromise. You can talk to them. Okay, so let's talk a little bit about the biophysical assessment, the biopsychosocial assessment. So think about that. Adolescence is a time of rapid physical, cognitive, psychological, and social growth. It's the process of becoming an adult. So each adolescent is unique. Each needs to be treated as such. And things like stressors, like trauma, loss, illness, and environmental factors can really slow or reverse the growth and development process. So think about that as well. In a general survey, you're doing physical awkwardness is normal at this period. So they may not want to get undressed, or they may be weird about that. Just give them their space, let them change into a gown, and also ask them if they want their parents present or not, because a lot of times they don't want their parents present during this. And they also don't want you to ask if they're sexually active in front of their parents. Do not do that. Okay, so think about this when you're talking to a child 10, 11. They might want their parents still in there. But 16, 17, 14, they might not, and that's okay. Determine the developmental level, the family composition, and the school situation they're in. They might be homeschooled. Health maintenance visits, especially adolescents between 11 and 21. We at least want to get eyes on them once a year. Height, weight, body mass index, blood pressure, lab values. Blood pressure, hearing screening, vision screening. Cholesterol starts between 9 and 11, especially now because we have a huge incidence of childhood obesity. So their normal total cholesterol should be about below or at 170. So this is the problem. We have a lot more obese children out there. So we really need to get them into care quickly so that we can get the blood pressure under control and things like that. I wish I couldn't have to say this, but that's literally what we're dealing with now is more and more diabetics, more and more type 1 diabetic, more and more obesity. So we really need to get a handle on that. And right now is the time that they can do that because one, their self-image is huge and they might actually make the change. A lot of these kids also are feeding themselves, clothing themselves and stuff, so they may want to have a bigger say in healthy foods and vegetables instead of pizza and tacos all the time. So really a lot of conversations happen with these guys. TB screening for at-risk adolescents if we know they've had close contact with a known positive person. If they're at risk, if they're from countries outside the US with a high rate of TB, if we know that they have any clinical conditions that are immunocompromised, such as HIV, diabetes, chronic renal failure, organ transplant. Users of IV drugs, incarcerated, homeless, or in care settings, and immunizations are based on the CDC website. So think about this. Most of the time, we're bringing them back in from an MMR, things to get ready for college, and also Gardasil. Biggest things that we see them for. Vital signs here in the chart, in your book. So just know your vital signs that are normal for this age. Think pre-adult. Okay, so your numbers are going to be more typical like an adult at the end of this stage. Some somatic complaints that could happen in this group: chronic pain, dizziness, sweating, headaches, chest pain, shortness of breath, GI issues, nausea, vomiting, diarrhea, back and joint pain. It might also indicate some home problems, some home avoidance problems. There's a lot of kids that live on the street because their parents refuse to parent. So anyone that's having home avoidance or you can't really get a good indication of where they live, that might be what you're dealing with. And again, backpack program and getting them into the system so that they are well supported. Anxiety, stress, depression in this group. Again, so some things that you would see in here might be like juvenile diabetes, juvenile arthritis, things like that would be the outside of this group. This group is typically healthy. So when they're not, they're added on to additional risk factors. So when performing a physical assessment, remember, respect their privacy, inform them of your actions, and explain the rationales. Usually if you explain, they'll let you do it. Focus on the positive aspects of the individual, so especially if they're a little heavier than normal of their peers, they already know that, they're aware. So just focus on the positive aspects. Oh, you've lost 2 pounds today. That's great, right? So address their concerns directly. Be cautious about pointing out physical abnormalities because they're very aware. Examine the genitals last and use the correct words for anatomy. It is a vagina, it is a penis. There's no more keywords for this. You do not want to say a pocketbook, right? Because a pocketbook could be misconstrued, okay? So use the correct words so that we can have really good conversations with these guys and know if they're being sexually abused or not. Remember, in this age, you also have a lot of high risk for trafficking, finding love outside of the family, so the potential for human trafficking is real. So you're just making sure that you have privacy and confidentiality for these guys, big time. Let's keep going. Skin. So skin's going to look more like an adult. You have to talk about sunscreen use, daily washing, acne, hormone stuff with oily skin and secretions. Check for tattoos, document them, document piercings, document birthmarks, moles, needle marks, or other skin abnormalities. We're usually using the 0 to 10 pain scale with them. Sometimes the parents will want you to talk to them about having a shower every day because I don't know why, but they tend to not want a shower and they stink. So that's usually the one that gets involved in that. 25 to 35% of adolescents will have body piercings other than the earlobes. So it's really important to know about this because research shows an association with body piercings and participation in high-risk activities. So you just want to know, why would you have a piercing in a special place if you weren't sexually active? So you need to educate adolescents and caregivers on the risks of body piercing, such as infection, allergic reaction to the metals, excessive bleeding, nerve damage, and dental complications like oral piercings. You can actually be taking the dental enamel off your teeth by clicking it against the teeth. So you just want to advise the individual to really think about infection control practices and make sure that those things don't get infected. So head, it's going to reach the adult size, so you're looking for brittle hair. Frequent drying, heat styling might cause issues, but also the nutritional status on this child. Also remember that in this age group could be the beginnings of anorexia and bulimia. So I know you had mental health, I know you understand those things. Looking for lanugo on a teenage child is a very real thing. Lanugo is fine baby hair, just like we talked about with the babies, the newborns. Think about it. It's a defense mechanism for your body to maintain heat because you're not eating enough nutrients. So we're constantly looking for anything like that that might indicate something's not what it's supposed to be. Eyes, so the acuity should be 20/20. If not, are they using contact lenses? Are they using colored contact lenses? Are they using glasses? Do they understand infection control with that? Eye makeup, so burning in the eyes, eyes that itch, sensitivity to light, pain in the eyes, swelling and tenderness from eye makeup. So being sure to make sure that you have those conversations with them as well. Ear trauma, piercings, gauges, infection, hearing loss. So if they're not responding to your questions or they're tilting their head to a certain side, might be an indication that they need hearing. Especially the high music levels of this age group, that's where that comes forward. Assess for the use of hearing aids, and hearing testing should be done once between the age of 11 and 14, 15 and 17, and 18 and 21. So still doing hearing screenings at school. Mouth, nose, throat, eyes, teeth, that whole deal, right? Piercings, looking for a nose that appears too large for the face. Looking for tooth erosion, that might be indicating vomiting. Third molars erupt, so you remember your wisdom teeth. If you didn't already, get them out. That's a big thing. Teeth grinding might be present in the issue of stress. You can also feel the inside of their cheeks, and they might have actually be biting the inside of their cheeks as well. So that's an infection risk. Who's doing this most of the time? The dental people, right? The dental people will do a full ulcer, the whole deal, while they're doing your teeth. But if you don't go get your teeth cleaned, they're not going to do that. So we do an oral sweep at least once a year. Inspecting the mouth for ulcers that could indicate inhalants or smokeless tobacco use. Tongue or lip piercings. Dental exam, dental cleaning, especially meth mouth. You just want to be very real about red gums might indicate periodontal disease. Periodontal disease leads to other issues. Dental erosions, tooth loss. What else? Misaligned teeth. They might have what's this called? TMJ, the mandibular grinding, right? So cervical lymph nodes for enlargement and fixation, looking for orthodontic correction to have occurred already. Usually misaligned teeth are most common between 8 and 16, and they might need either braces or whatever. Palpate the thyroid. They may have the beginnings of hypothyroid at this point if they aren't already on it from childhood when we did the PKU. Cardiovascular should be near adult size, looking for innocent murmurs and screening for iron deficiency anemia if at risk. So anemia, we'll talk more about it later, but your sickle cell crisis and things like that are involved in there. Respiratory, the length and diameter of the lungs continue to increase during adolescence. The history of asthma, the #1 chronic illness in children. Lung sounds should be clear, and you're just looking for any respiratory issues, anything that affects sleep at night, any sign of barrel chest or clubbed fingers. It's very rare. The biggest respiratory issue you're going to come into contact with is cystic fibrosis. So gastrointestinal, nutrition status, constipation, diarrhea, vomiting. Chronic abdominal pain could be an indication of stress and anxiety, especially around tests. So just being aware of that. Renal now comes into play. Remember hydration status, urinary tract infections, especially if they're sexually active. So reminding them front to back, cotton underwear, the whole deal. Avoiding constipation because that's going to lead to UTIs as well. And then reproductively, we check breast self-exams, boys and girls, testicular self-exam as well, and clinical breast exams yearly. The first gynecological exam should occur between 13 and 15, especially talking to them about guidance and preventive services. Whatever that means to them, if they need pelvic exam, if there's pain or abdominal bleeding. Typically, in the beginning of menses, the periods aren't that regular, and especially if you have anorexia, they may actually have cessation of menses. So a lot of things come to play with that. Pap tests are no longer conducted until the age of 21, so you don't need a pap smear right away. Unless you're sexually active, of course. Hernia checks, prostate checks, testicular self-exams for the boys, STIs, genital discharge rash, and then you're looking for any signs or symptoms of abuse, such as bruising, skin tears in the genital areas, anal areas, and then as well, we have seen and have included child abuse to be genital warts in those areas as well. So think about that. If you're 16 and you have genital warts, what's going on, right? So that's a key indicator. Pregnancy can occur during this age at any time, so we really want to be on the forefront of that. Puberty is the process of becoming reproductively mature, and a lot of people do not realize that they are able to get pregnant that early. Puberty begins for girls between 8 and 13 and is completed in about 4 years. Puberty begins at 9 to 14 and is completed about 3.5 years for boys. So think about the estrogen, the progesterone, and the androgens going crazy. Boys and girls will experience a growth spurt that lasts 24 to 36 months. So that growth spurt happens between 10 and 12 for girls and 12 and 14 for boys. Lean body mass will decrease in girls and increase in boys. Adipose body tissue, again, adipose fat tissue increases in girls, decreases in boys. And both sexes will develop coarse hair in the pubic area and underarms. Breast development begins between 8 and 10, unless they're precocious puberty. Again, one breast may develop faster than the other. Breast tenderness is common, especially during their beginning of their period. And then also boys, remember, one testicle is always larger than the other as well. So precocious puberty happens when breast development happens a little earlier than we expect. So you can see in the chart that the breast bud starts, and then the elevation of the breast and the nipple increased in diameter. The areola turns darker in color and further enlarges, and then glandular tissues begin to develop underneath the areola. The biggest issue is if they were to get pregnant earlier on, they're not going to be able to breastfeed because they just don't have the mature breasts yet. That's our biggest issue. Now, this same process happens in boys, so think about that. In boys, we call it gynecomastia. So gynecomastia is the abnormal breast tissue in boys, and that's usually self-limiting, and it's related to the increase in sex hormones, and more common in overweight boys. Girls begin menstruation or the shedding of the lining approximately 2 years after the onset of breast development. So just remember that. Leukorrhea is the white discharge from the vagina seen at 3 to 6 months before menarche. Periods can be irregular up to 1 to 2 years when they just start, and they become more regular over time. So this is typically the reason why they come into the GYN office. Girls can become pregnant after the first menstruation. So again, it's one of those times where we really need to be ahead of the game on that. Premenstrual syndrome, irritability, anxiety, depression, crying, mood swings, feeling bloated, breast tenderness, and fatigue. So we typically talk to them about taking some ibuprofen. That will help that, especially the back pain. And then you just assess for cessation of menstrual periods after an established, because it's usually a drop in body fats by excessive exercising, deliberate food restriction, otherwise known as potential pregnancy or anorexia. Pregnancy also should be always evaluated. Just double check if somebody comes in the ER talking about pain in the genital area. It could be a tubal pregnancy, or it could be a pregnancy at any time. Secondary sex characteristics, male and female voices deepen. Boys have an Adam's apple. Coarse hair becomes dark and thick. Hair grows under the underarms and in the legs, and scrotum and penis enlarge in the boy. Neurovascularly, you're looking for judgment. Again, sometimes remains underdeveloped until the mid-20s. Equal strength on left and right hand grips and equal tendon reflexes. Musculoskeletally, you should see muscles are growing during puberty. Hands, feet, arms, legs, clumsiness. Female pelvis widens during puberty. The growth plates and the long bones close at age 20. So that's always a lovely test question. I love to ask about growth plates and when they close. So 20 years old, you're as tall as you're going to get. Fractures in that area are common, and they jeopardize long-term growth of the long bones. So a test question might be, the mom says, is he at risk? Well, if the fracture happens at that area of the long bone, that could jeopardize long-term growth. Growth hormone, just remember growth hormone's in the brain, and that causes giganticism or dwarfism, right? Just keep reminding yourself of all these good things that you've learned along the way. Scoliosis checks from 10 to 12. And socially, you're looking for challenges of values, traditions, and beliefs of the family as they develop their own value system. They want independence from their caregiver. They have conflicts with their caregivers. You'll hear it. You need to resist being in the middle, right? So depending on family in times of crisis, they have a best friend and they idealize friendships. So you can see typically in gym class or in swimming, you have your swimsuit on already. It's the perfect time to talk about scoliosis checks. So you'll see that in your book. You're looking for cliques, compare themselves with others. They strive for peer acceptance. They explore gender roles. They seek out information on sex. They start having sexual feelings and sexual orientation is developed, and they start developing intimate relationships. Romances can be brief but very intense, and they could have feelings of love and romantic fantasies. So again, talking about internet safety, sexual identity. Spiritually, they start talking about joining or not joining a religious belief of their family. They may disagree with their family on that. Adolescents understand the permanence of death and start asking about an afterlife. Remember, in this age group, suicide precautions. Okay, so now going into medications, think about medications in this. Typically, there's not going to be a bunch of drugs to give these kids. Some medications are labeled for use in adolescents older than 12, 13, or 17, but most of the time the pediatric labeling is going to go away and it's going to go to an adult dose. Again, eye drops, nasal sprays, ear drops, they should be able to do that themselves. They're going to college, they should be able to understand medications, understand labels and timing of medications. Hugely important in case they have some kind of surgery and get pain meds so that they don't end up overdosing themselves on the pain meds. Again, if they've never been to the hospital before, just like an adult, be careful with any opioids, any narcotics. They're opiate naive until they have had some. So some people will react very differently to a little bit of a drug. You're just always being careful with that. If the patient has a G tube or a gastronomy tube or an NG tube, still going to encourage self-administration of meds and stuff on that. So that could be a long-term patient that's giving themselves their own feedings. It could also be an anorexic that's having to do tube feedings until they master gaining weight as well. Rectal meds, they should be able to do that by themselves. Sub-Q meds, again, they should be able to do by themselves, especially if they're doing insulin. They've done it for years. You could use Emla cream on them. Most of them will just shrug it off. Remember, during this period of time, there's a lot of changes in the way meds are absorbed, metabolized, and eliminated. So metabolism of medications are affected by puberty. Some medications will be metabolized faster because of the puberty. Medication metabolism decreases to adult levels after puberty. And nurses can only rely on symbols, phrases to warn adolescents of medication risks. So we should always be talking to them about medication labels and warnings about medications, especially the ability to drive on a medication, because they're not used to that, right? They're not going to know that. So make sure talking. Again, some cultural competence. So bioculturally, we know that Asian descent, they might metabolize different medications slower than average individuals. So being careful with that. Make sure that they know, try a medication at home, see how you do on it before you go out driving. You might not be able to get back home. The adolescent patient, we're always obtaining guardian consent, but this might change state by state. So again, always obtain assent from the patient. Obtain rationales, explain rationales to patient and family. Show equipment, be honest. Be honest if it's going to be painful or uncomfortable. Maintain patient confidentiality. And when performing a procedure in the area where multiple adolescents are lined up, just be very careful and ensure the privacy of each individual and don't announce results in front of others. Flu shot clinics, things like that, right? So one of the things that we talked about is heads. So heads can be summarized. So the way that you talk about health promotion with adolescents, home, education, activities, drug diet, sexuality, suicide, and safety are our big things that we're looking for. So there you go. Heads, home, education, activities, nutrition, diet, drugs, sexuality, suicide, safety is how we assess and educate on these kinds of guys. What age is a patient considered to be in middle adolescence? Remember that? What did we say? Middle adolescence. The middle adolescence, if you remember that I said 15 to 17 is middle adolescence. So 14 to 17, 15 to 17, this is the beginning of adolescence. This is the middle, and this is the end of it. Okay, so emergency care. What emergencies are going to come in? Think about primary assessment. It's going to be a physical assessment. Home assessment, you're talking about who's the caregiver, education, what grade are they in school, activities that they're in, talking about concussions, diet, drugs. Oh, what else? Talking about substance abuse, screening for substance abuse, nutrition assessment, sexual assessment. We kind of talked about that. So emergency care now, most of the time it's going to be traumatic injury due to risk taking, so the sense of immortality and the disconnect between cause and effect. So think about, what are they doing? They're starting to drive, they're starting to be a passenger in a car. So a lot of things have to do with accidental or intentional alcohol and substance abuse, overuse, overdose, motor vehicle accidents from that, sport injuries, sexual assault, and mental health emergencies. So just to go over those, don't lecture to somebody in the ER about drugs and alcohol, right? Be very careful about that. So remember your ability to recite the ABCs: airway, breathing, circulation, primary assessment. Skin for drug use, so we're looking between the toes, in the arms, anywhere you can imagine, especially between the toes, because they know that we look in their armpits, antecubital spot. Do not resuscitate status needs to be talked about. More times than not, we're going to do everything possible, right? So we really need to know if the child does have a long-term illness, what's the decision on the resuscitation. If something happens during a car accident, that's where that comes into play. So we really need to know. Think also, a lot of these kids end up being organ donors for others. So identifying parents, guardians, identifying the patient's legal status, if they're emancipated or not, if they're mature enough to make their own acts. If it's ever anything to do with an STD, they have the right to do that by themselves. You cannot call the parents to ask for that. Contextual information about the injury or the condition, the family social history, the immunization status, and transportation availability, especially if they're being discharged from the ER. Remember, you cannot discharge somebody on drugs, right? So if you give them pain medicine, we can't let them go home until that pain medicine is out of their system. So they'll need somebody to drive them home, which might give them a very bad opportunity to talk to their parents about coming to get them. So additional considerations, think about the availability of age and size appropriate equipment. Don't say, I need to go get the pediatric cuff. Don't say that. Speak to adolescents privately, ensuring confidentiality. It gets them less threatened. Allow adolescents and caregivers to decide together. So have family members present. Some adolescents will have the capability and desire to make medical decisions on their own, so that should be encouraged and supported. You're being a patient advocate, but also providing education for the family and the patient. You want to sensitively convey bad news to caregivers or those who might not be present. So we usually typically have a sensitive subject talk, and we might have to facilitate some of those conversations between the adolescent and the caregiver. In the ER, we do this almost daily when we have something going on. So we may actually call in the ethics committee or the chaplain to help us with that as well. Child protective services might need to be called. And then just prepare for the possibility of transferring the patient to a more appropriate facility. They might be in your ER, but they need care at Johns Hopkins or somewhere like that. Ask the adolescent for a secure email address or phone number when providing sensitive follow-up information, including results. They may or may not want the parent called. Acute care hospitalization, just remember these guys have a mind of their own, and you must establish roles and boundaries right off. So you want to establish that patient-family relationship. You want to be the adolescent's professional helper, not their friend, not their parent. Be consistent, set expectations and consequences for language and behavior. Be respectful, be non-judgmental, develop trust with them, understand unique concerns of adolescents, and use humor appropriately. What you think is funny may not be funny to a teenager, right? So just being careful about that. In the environment, you need to double check all the time about suicide risk. Offer private telephone access. If they're not on activity or diet constrictions, let them do their thing. They prefer other adolescents as roommates, remember that. Avoid a wide variation in ages, especially with roommate selection. Privacy curtains, medical equipment, make sure that alarms are turned down. Comfortable furniture, extra chairs, physical space. They want to prefer a home-like environment as much as possible. So think about like posters of athletes and stuff instead of cartoon characters in their room. Orientation materials and visitation hours need to be talked to about with the patient and their parent as well. And just providing a sense of control will help reduce their feelings of anxiety while they're in the hospital. Provide treatments in private, cluster activities so that you're out of the way for homework and visiting with friends and family. Patient education, show the patient the equipment ahead of time, be honest, use the appropriate size tools, and fall risk. Fall risk is Humpty Dumpty in some ages, and then they go to the adult scale. Remember that chronically ill adolescent patients also involve in our care. So that might be tube feedings, NG tube feedings, ventilators, the whole deal. So again, totally a good specialty to get in if you like it. Most insurance companies pay premium dollars for nurses at the bedside with one patient. Spiritual care, ask if they want a spiritual person involved, promote self-esteem and confidence. Home care, collaborate with the medical team and the patient and the family. Adolescents have increased opportunity for socializing with peers, so remember that with medical situation. Many believe encouraging adolescents to get involved in their own care, and it can be challenging because you may not be able to provide them and their parent access to their medical record. Thinking about that, we might have to put the parent in as well, which could be a consideration if there's anything STD related. So what else? Let's talk about that. The benefits is that they know what they're doing if they have access to their record. Complementary medication. So this is where people start taking herbal and dietary supplements. So you just want to be very clear that we need to know about those. So some of the commonly dietary supplements that could be used: omega-3 fatty acids, melatonin, probiotics, botanicals, vitamins and minerals, but also they could be using honey, lemon, green tea, and chamomile tea. The top 6 herbal remedies include chiropractic care, yoga, deep breathing, meditation, and homeopathy. So you need to always ask if they're doing that. Acupuncture, acupressure, hypnosis, essential oils, and aromatherapy. Complementary medicine has its place in our world, and we need to make sure that we are aware if people are using that, because there are some interactions with medication. So it's always the appropriate thing to ask about it and chart it, and then have a pharmacist come up and double check that things are okay being used together. Child abuse considerations, these people are still in that risk factor, especially LGBTQIA, living in a detention facility, alcohol and substance abuse, date rape, drugs, having a disability puts them at risk for abuse. Non-specific physical complaints could be an indication of sexual abuse. Adolescents are more at risk for sexual abuse. They have higher risk for pregnancy, self-harm, poor academic performance, sexual promiscuous, and being alcohol and substance abusers. So we definitely want to, keep an eye on these guys. Sexually abused adolescents have an increased risk of mental health problems, depression, anxiety, eating disorders, and PTSD. So just being careful with that. Again, with the sexual assault prevention, talking a lot about avoiding sexual assault, going out with a group of friends, those kind of situations come up, and we need to talk about that openly and honestly with our teenagers. Human trafficking, again, California, Texas, Florida, Ohio, and New York are the top 5 states. So that is truly a problem here in Texas and Florida. And we need to be aware of that. 25% of human trafficking victims are minors, aged 12 to 14. So looking for STIs, UTIs, multiple pregnancies, abortions, miscarriages, dental disease, burns, malnutrition, mental health issues like depression, anxiety, PTSD, and suicide attempts. So healthcare providers play an important role in identifying victims and assessing their needs. When you become a nurse, you will have a whole training on this. That is one of the things that Florida recommends and requires as well. So just thinking about that. The other thing to do with sexual abuse. So rape, it's a good question to have on the NCLEX. They typically ask you what to do or who to call back, and they'll give you 4 patients. Remember that the person who has experienced rape needs to have the first callback most of the time, because you need to tell them, do not get in the shower. Okay? So remember, sane nurses are nurses that are specially trained in the ER for sexual assault victims. So they are nurse examiners, and they're the first people that get called into the scene when there is a patient coming into the ER saying they have been sexually abused. We need to get them there because they are the person that will talk to the patient and get all the evidence they need prior to allowing her to shower. So super important on the NCLEX. You've got to remember that. Anytime there's sexual assault, we do not want them to shower. What's the first thing a young girl's going to do? Want to shower, want to get rid of that guilt and that thought and that the whole thing, right? We got to tell them, don't shower. Go immediately to the ER because we're going to lose valuable evidence. Okay, question at the end. In emergency care of the adolescent, which of the following is included in the primary assessment? What do you think? What do you think? Did we talk about ABCs? Yes. Did we talk about assessing the skin for evidence of drug use? Yes. Immunization status, hugely important. Okay, so the answer is all of the above. The ability for the patient to recite ABCs, airway, breathing, circulation. Checking the skin for drug use. Acquiring the patient's immunization status are all part of your primary assessment. All right.